This is the last session for the third day of the conference. Our speaker would be for nuclear medicine, and Dr. Saleh Osman. He is associate professor in King Saud University, and he is head of the unit of nuclear medicine in the university. He will talk to us today in two topics. The first one would be pediatric GI scintigraphy, and the second one would be cardiac scintigraphy.
Bismillah ar-Rahman ar-Rahim. May I thank the organizing committee headed by Dr. Muslih al-Raddadi for inviting me to this interesting conference from which I attended the session before lunchtime and the previous lecture, and I believe that it's achieving its target of evidence-based radiology. Before lunchtime, Dr. Sayes showed how also nuclear medicine can be evidence-based, showing the role of HIDA in proving that the patient has a biliary leak, and that was very evidence on the slide he showed before lunchtime. In the next two presentations, I'll go ahead confirming how nuclear medicine also can be evidence-based and how we achieve our targets if we do the procedures properly. The first presentation will be about common procedures of nuclear gastroenterology in pediatric patients, which we are performing at King Khalid University Hospital, where we performed around 5,000 procedures in 2011 when we had only 2 gamma cameras. Last year in 2012 we performed 8,000 procedures because we got 2 more gamma cameras. Next year we'll have 4 more gamma cameras, so we'll be one of the largest nuclear medicine departments. And that reflects how the large confidence of the referring physician in nuclear medicine and its result. In 2011 we performed around, I said 5,000 procedures. 57 procedures were only for gastroenterology, and that was 6% of our procedures, and that is a considerable number of procedures of the total procedures. We can perform, we can study the gastrointestinal tract from the parotid gland, the esophageal transit time, the gastric emptying, gastroesophageal reflux study, the milk scan, GI bleeding, Meckel's, Helicobacter pylori, hepatic hemangioma, liver spleen, colloid study, hepatobiliary study, Levine shunt evaluation, patency, protein losing enteropathy, infection imaging, and right to left shunt in patients with hepatopulmonary syndrome. But I will stress only on 4 commonly performed procedures within the pediatric population. We will start with the milk scan. The milk scan is we will see a case of 3-month-old female patient who had recurrent attacks of vomiting and chest infection, and the barium meal was negative. pH monitor was not conclusive, and milk scan requested to rule out gastroesophageal reflux and pulmonary aspiration. This was the gastroesophageal study which we perform. We have a special procedure at King Khalid University Hospital, which is unique in the kingdom. We perform 4 sets of images. We do the first set while the patient is supine. Then we put the patient down on his tummy and do a prone. Then left decubitus and right decubitus. Because as you will see later, a reflux can happen in one position and not in the other 3 positions, or can happen in several positions, and that's very important at the time of treating the patients. So this patient has positive reflux in prone position, as you can see here, while it is negative in all other 3 positions. Four hours after the initial study, we bring the patient back and we take chest images. This is the markers on the shoulders, and this is the stomach. So we don't see any abnormal activity in the lung. So this is a good example of positive gastroesophageal reflux in prone position, negative in other positions, and negative for pulmonary aspiration. Milk scan is called milk scan because we label the milk with radioactive material and we give it to the patient through NG tube or orally, the importance of using the milk, that it's the physiologic process, the physiologic fluid that the baby is taking. So we are assessing the baby, the functional status of the gastroesophageal reflux. So infants referred for milk scan because milk is labeled, as we said, with technetium sulfur colloid. The dose is given to the patient. You can give it orally, drop it in the patient's mouth, then you give the whole non-radioactive milk, or through NG tube. So it's very practical, and you have the option in not using the NG tube. And the indications is to detection and the quantitation of gastroesophageal reflux and detection of pulmonary aspiration. The patient should be MPO for 4 hours, or you can skip the last breastfeeding. Mix 300 microcurie of technetium colloid with 100 milliliter formula or milk and give it through NG tube. And you acquire serial images, as we said, 30 seconds each for 15 frames, 8 minutes, acquired in supine, prone, and decubitus positions, as you will see. So this is, as we said, this quadrant represents the prone, and this is the supine, this is left side down, and this is right side down. Then you acquire the late image to see if there is any reflux, and then you can quantify the reflux by drawing region of interest around the esophagus and around the stomach, and you can see the time activity curve confirming the reflux. Also, you can calculate the gastric emptying on request of the referring physician if he is interested in getting the T-half of the gastric emptying, which is the normal value is 30 minutes for a fluid usually. This is a patient, 5-month-old male patient with recurrent attacks of vomiting, suspected pyloric stenosis, and milk scan was requested to rule out gastroesophageal reflux and assess gastric emptying. The study was positive for reflux in different positions, here in the prone and here in the right decubitus, while it was negative in other positions. And the gastric emptying was calculated, and the T half was 88. The gastric emptying was calculated, and it was within normal. By 30 minutes, 88.5% of the stomach content passed to the duodenum. So the gastric emptying was normal, and that excludes significant pyloric stenosis. The conventional technique, which only takes one position, this is a patient 3 months old with recurrent attacks of choking while feeding and cyanosis, and the barium meal was negative. The milk scan done in the patient supine was negative. So this confirms the importance of doing the 4 set of images to detect the reflux, because the conventional method can only detect position reflux if, when the patient in supine position, while our technique can detect reflux in other positions not seen in supine position. Another thing is, which is important, that the reflux is not a constant process. So if you perform a milk scan and it comes negative, you can repeat the study after a week, because the patient may have attacks of reflux at during some time, which disappear during at the time of doing the scan. So that is a justification for repeating the scan. This is a patient which had a milk scan on 22nd of April 2006, and the study was negative. The physician ordered to repeat the scan, and the study was repeated on 5th of May of the same year, and the study was positive for gastroesophageal reflux in prone position. The advantages of the milk scan, that it is safe with less radiation dose compared to barium meal, reliable physiologic screening test because we are using milk, more sensitive than barium meal and manometry in detecting reflux. The percentage yield of positive GER is position-related technique, and is 3-fold than that of conventional technique. So I suggest to nuclear medicine people to shift to this technique. The sensitivity of milk scan around 60 to 90% compared to pH monitoring, and the specificity more than 90%. The limitations of this technique, it cannot distinguish between physiologic and pathologic reflux. So it's very sensitive, but not very specific. And the low sensitivity for detecting pulmonary aspiration. The sensitivity is very low. It is down less than 25%. We published this article in the Nuclear Medicine Communication about the multi-view technique, which was accepted and published immediately after submission. Now we move to the lower GI bleeding, mainly the Meckel's scan. This is a 3-year-old male presented with sudden painless rectal bleeding. The Meckel's scan was requested, and here you can see a foci of increased uptake of similar intensity as the stomach activity. This is seen also in the anterior view, in the serial images. This is indication of ectopic gastric mucosa in the lower abdomen, consistent with Meckel's diverticulum. So, what is the Meckel's diverticulum? Meckel's represent a persistence of the omphallomesenteric duct located within 2 feet of the ileocecal valve, and found in 2 to 3% of the population, with the majority identified in children less than 10 years of age. 30% contain ectopic gastric mucosa, and the ectopic gastric mucosa is present in only 60% of symptomatic children, and in greater than 95% within patients with GI hemorrhage. This is important because when we report the Michel's scan, we don't call it normal, we call it negative, because the patient may have Michel's diverticulum, but he has no ectopic gastric mucosa to concentrate the tracer. How it is performed? The Michel's is diverticulum study reveals the pertechnetate within the abdomen. The pertechnetate is secreted by the mucosa of the stomach as well as by the ectopic gastric mucosa wherever it is. So if there is ectopic gastric mucosa and Barrett's esophagus also, you can see it at the same time. Because pertechnetate exhibits weak protein binding, it is also filtered by the kidney, and you should be remembered not to confuse that with ectopic gastric mucosa activity in the ureters. The indications: detection and localization of a Michel's diverticulum containing functioning gastric mucosa, and detection and localization of pathologic structures containing gastric mucosa, as well as I said, the Barrett's esophagus. The procedure is very simple. The patient should be in PO for 4 to 6 hours. We use technetium pertechnetate, which is available in all nuclear medicine departments, and serial dynamic studies are acquired. This is the flow study, and this is serial dynamic images showing a negative study. Sometimes you need to use pharmacologic intervention such as bentagastrin, which enhance the uptake of pertechnetate by the gastric mucosa. But may result in a washout effect. Glucagon inhibits the peristalsis, dilution and washout of intestinal radioactivity, and cimetidine inhibits the release of pertechnetate in the lumen of the Michel's diverticulum. So to increase the sensitivity, we usually give the patient cimetidine, so it will impair the secretion and the intraluminal activity. So we will decrease the number of false positive cases. There are some agents which suppress the uptake of pertechnetate and can give false negative results, such as potassium perchlorate and atropine. So you inquire from the referring physician whether your patient is taking these agents. Other techniques which limit the study include aluminum hydroxide ingestion, overlapping organs, and insufficient dose of radioactivity. And this is an example of Michel's scan. The criteria for a positive study consist in the appearance of a foci of increased uptake at the same time of the stomach, and increase in intensity in parallel way to the stomach activity. This is a positive, the criteria for a positive study. This is a young patient, 16 years old, a male, who presented with a bleeding per rectum, and they requested labeled RBC. On the labeled RBC, we see a foci of increased uptake here in the right lower abdomen. But the criteria for labeled RBC in GI bleeding, that the extravasated activity within the lumen should travel through the intestine. We followed this foci and remained fixed at the right lower abdomen. So this was against a bleeding mucosa. or bleeding source of, within the GI. So we suggested to the referring physician to repeat the study after a few days to rule out Meckel's scan. And we did Meckel's scan, and the patient was operated, and the Meckel's diverticulum was found. So in patients with GI bleeding to whom you perform labeled RBC and it comes negative, suggest to the referring physician to consider the Meckel's diverticulum even in adult patients. It is rare to find Meckel's in adult patients, but it has been reported in the literature that can happen in up to 10% of adults may have Meckel's diverticulum. So, causes of false negative studies. As I said, when I report a Meckel's scan, I tell you that the Meckel's negative study for Meckel's diverticulum. And causes for Meckel's negative study are small size diverticulum, absent gastric mucosa, or the mucosa has autonecrosis and obscured by activity in normal structures. So when we do Meckel's scan, we are not visualizing the site of the bleeding. We are visualizing the ectopic gastric mucosa surrounding the bleeding foci. So this should be clear that we are not visualizing the bleeding foci per se, but the ectopic gastric mucosa surrounding the bleeding foci. The ectopic gastric mucosa in the intestine is excreting HCl, and unlike the stomach, there is no protecting layer within the intestine to protect it from the HCl. That causes ulceration in the intestine and the bleeding because of the effect of the HCl. This should be clear for all, that we are not visualizing the bleeding foci, but the gastric mucosa surrounding it. The false positive results, you can have false positive results, but an experienced nuclear medicine physician, he can easily overcome these false positive causes, like normal activity in GI tract, kidneys, and urinary bladder. If there are activity in the kidney or in the ureters, just give small dose of Lasix and repeat the study after that, and will tell you whether activity within the ureters or not. And if you take also lateral views, if it is posterior to the back, then it is related to kidney. If it is anterior, then it is in the abdomen. Increase the blood pool due to inflammation like intussusception or appendicitis. These can be causes of false positive as well. Hypervascularity like tumors, AV malformation can cause false positive results. So, GI bleeding in children may be caused by Meckel's diverticulum. Meckel's diverticulum pertechnetate uptake appears parallel to that of gastric mucosa in time and intensity. Sensitivity is high, 85%. Pharmacologic intervention may improve the sensitivity. The specificity also is very high, reaching 95%. The third common procedure is the HIDA scan, and usually performed in neonatal jaundice to differentiate between biliary atresia and neonatal hepatitis. This is a 1-month-old infant with neonatal jaundice. HIDA scan requested to determine the cause of jaundice, and the scan here failed to visualize the gallbladder and the biliary system, confirming that this is a biliary atresia. The study, when you do it for biliary atresia, you should follow the patient up to 24 hours post-injection, and the lack of activity in the abdomen and the non-visualization of gallbladder and biliary system is consistent with biliary atresia. The HIDA scan is performed, as we said, to assess the liver function and not the Kupffer cells. So we don't here see the spleen using the HIDA because only we look to the hepatocytes. The procedure is commonly referred as by mistake as HIDA. It is not HIDA. At the start it was hepatobiliary immunodiacetic acid. The HIDA stand for hepatobiliary immunodiacetic acid, and it is labeled with technetium 99M. So now we have other agents than HIDA. We have D-SIDA, iodida, B-BIDA. So the basic is the immunodiacetic acid, which is a bilirubin analog and compete with the hepatocyte with the bilirubin. So if the hepatocytes are saturated with bilirubin, the HIDA cannot be taken up by the hepatocyte. So if the bilirubin is more than 30 milligram, then the study is the patient should be prepared properly to free some hepatocytes from bilirubin to give site for the HIDA to be taken. And that's achieved by giving the patient phenobarb for 5 days before the procedure. So the patient preparation, you give 5 milligram per kg per day, 5 days prior to the study. And the reason for giving the phenobarb is to enhance the bilirubin excretion from the hepatocytes and to allow the HIDA to take place and to be excreted. So you will see the gallbladder and the biliary system and consequently the bowel activity. You acquire studies, flow study, then you acquire sequential images, and the appearance of gallbladder and bowel activity exclude biliary obstruction. This is a normal finding. You should see the gallbladder within 30 minutes of injection, and activity in small bowel should be not later than 60 minutes, and that exclude the biliary obstruction. The interpretation criteria for biliary atresia: there will be good prompt liver uptake with high liver to heart ratio at 5 minutes, and the hepatic extraction more than 92%, liver retention with no excretion, and non-visualization of activity in the gallbladder or in the bowel by 24 hours post-injection. This is positive and indicates biliary atresia in children less than 3 months old. So the sensitivity of HIDA decreases after the 3 months of age because biliary cirrhosis will take place, and that will affect the liver function, and the sensitivity of the HIDA scan will drop down. For neonatal hepatitis, the criteria is different. You will see poor liver uptake with prolonged blood pool activity reflected by seeing the heart activity. Then poor biliary excretion. You don't see the biliary system by the end of the study, but when you follow the patients 2, 3, 4 hours and 24 hours, you will see activity in the small intestine. So this indicates medical jaundice and not biliary atresia. So in infants with conjugated hyperbilirubinemia, the primary differential diagnosis is between biliary atresia and causes of severe hepatic insufficiency, such as neonatal hepatitis. The diagnosis of biliary atresia should be done early, before the age of 3 months. Neonatal hepatitis will show poor liver uptake but delayed excretion to small bowel. while biliary atresia, there will be no activity in small bowel up to 24 hours post-injection. Finally, I will talk about one topic which is not common, but if you come with a patient with hypoalbuminemia, a child with hypoalbuminemia, remember that we can help you performing a protein losing enteropathy study. This is a 12 years old male patient who presented with lower limb edema, diarrhea, abdominal pain, and weight loss. The referring physician requested technetium human serum albumin to rule out protein losing enteropathy. The procedure is very easy and can be performed in any nuclear medicine department. You label the human serum albumin with technetium and you inject it to the patient, and you take serial images up to 24 hours post-injection. Early images, you will not see activity extravasating in the bowel lumen. While on delayed images, 24-hour delayed image, we could delineate the large bowel clearly because of the extravasation of the albumin into the bowel. And that's the, I know it's rare, but it's worth keeping it in mind in such a group of patients. So, protein losing enteropathy is a rare complication of a variety of intestinal disorders characterized by excessive protein loss into the bowel lumen. It is an important advantage of our procedure is to localize the site of a protein loss. Several radiopharmaceuticals can be used, but the most commonly used is the human serum albumin. The tracer, as we said, injected intravenously, and you acquire serial images of the abdomen. And the sensitivity is 96% and the specificity 100% in detecting the protein. No, because I started late, so you should be generous with me because anyway, this is the commonest causes of protein losing enteropathy in the affecting the mucosa or lymphatic abnormalities, and these causes can be lead to protein losing enteropathy. The nuclear medicine gastroenterology procedures are very simple, sensitive, safe, and non-invasive. You can quantitate the results, and you can repeat it as frequently as you want. And Dr. Muslah is giving me 10 minutes to a very important topic to all of you, not only as physicians, but also as people who should be interested about ischemic heart disease, because as I said, I believe we should be more than film interpreters, and we should interfere in the patient management. The myocardial perfusion imaging, as I said, in 2011, we did around 5,000 procedures, and more than 1,100 procedures were for cardiology. Last year, we duplicated this number because we are doing now daily 10 nuclear medicine patients to assess myocardial perfusion and to evaluate patients for ischemic heart disease. So I will go very fast to tell you what is the myocardial perfusion imaging, how it is performed, how to read it, when to do it, and what's the prognostic significance of MPI in this group of patients. What is MPI? MPI is myocardial perfusion imaging, is a nuclear medicine technique that assists the myocardial perfusion and indirectly the blood flow in the heart by taking serial pictures around the chest after injection of radioactive tracer into the blood. So we will show function rather than structure. When you think about myocardial perfusion, remember this image from the Arizona deserts, that this flow, and you remember that can be a coronary, can be patent, while the surrounding tissue is dead. So although the flow is normal, the perfusion is very poor. While in this image from the Amazons, you can see there is narrowing in the river, but the perfusion of the surrounding territory is preserved, so it is normal. So the flow does not the anatomic imaging does not always reflects the real myocardial perfusion. Translating that to image, this is a calcium score image showing there is narrowing of one of the coronaries, but this narrowing did not affect the myocardial perfusion because the surrounding tissue is healthy. While in this patient who has myocardial infarction underwent CABG, they restored the blood flow, but the perfusion did not. So this patient did not benefit from CABG. So now to go back to the main topic, what are the radiopharmaceuticals used? You can use either thallium or technetium agents labeled with tetrophosmin or systamine. The thallium is a potassium analog, and the uptake of thallium by the myocyte depends on the sodium-potassium bond, while the MIB or the tetrophosmin are liposoluble agents, and they are diffused passively to the myocyte and concentrated within the mitochondria. And once they are there, they don't redistribute like thallium. So the thallium, after injection, 30 minutes after injection, it will redistribute in the myocardium, while the technetium agents, they don't redistribute, and for that reason, we use 2 doses of technetium agents when we do myocardial perfusion scan. We assess the patient in resting state and during stress. We can stress the patient by treadmill, either submaximal exercise, symptom-limited exercise, or maximal exercise, or by pharmacologic stress. Most of our patients, they cannot run on the treadmill, so we can use vasodilators or ionotropic agents to stress the patient and to assess the myocardium in resting and during stress status. You have many choices. You can do 1-day protocol, 2-day protocol. You can inject nitrate to assess the myocardial viability and improve the your test. These are the cameras we have now in our department. We have one Bright View. We have one SPECT XCT used for attenuation correction, and this is dedicated gamma camera for the cardiac. We have 2 cameras like this, one like this and one like this. This is summarizes what we said. The patient is stressed, then injected. The patient lies on his back, and the camera rotates around the heart to take several views of the heart, and the images are reconstructed to give you a 3D at the end of the story. How to read an MPI? This is during restless status. This is a shortcut of the heart. The heart should look like a donut, complete donuts. Then you stress the patient. If a defect develops in the inferior, like this patient in the inferior wall, this is a stress-induced ischemia. So we assess the perfusion within the resting status. We stress the patient and we assess perfusion in the inferior wall. Now we risk stratify the patient. The patient comes to the triage clinic with risk factors, and they send the patient for risk stratification. Those patients whose scan comes as high risk scan, with some distress score more than 13, those patients should go for cath and PCI. Those patients with intermediate or low risk scan, these patients can be managed medically. This is 42 years old male patient, asymptomatic smoker with hyperlipidemia, annual stress test, ECG normal, CT coronary showed calcium score positive, and life insurance premium was increased because of the calcium score. The MPI was done and was completely normal, and the life insurance premium was unchanged, so he did not pay any further payment to the insurance company. In the emergency department, now we frequently, they call us from the emergency that there is a patient with chest pain. We want study MPI during the chest pain. So they send the patient for technician scan. We do the scan during the chest pain. If the scan is normal, like in this patient, then the patient can be discharged and you can exclude significant ischemic heart disease. A patient with normal myocardial perfusion scan has a chance of less than 1% to have cardiac event in the coming year. So the prognostic value of a normal myocardial perfusion image is very good. This is a patient, 54 years old male with diabetes mellitus, hypertension, exertional chest pain, and the diagnosis was inconclusive because of the inconclusive ECG. MPI was requested. Because the angio and the MPI revealed a reversible perfusion defect in the anterolateral wall and in the apex, which was normal at rest status. The angio was done. There was 50% LAD disease, 70% diagonal, and 80% RCA disease. The patient had bypass grafting. This is another patient of the courage trial. This is during stress, and this is during rest. You can see the clear difference. This is at rest status. When the patient was stressed, there was a severe hypoperfusion in the septum and in the anterior wall, as well as in the apex. So this is the patient was cathed, and there was 70% LA disease and 70% marginal disease. So this is considered a high risk scan. I'll move to unstable angina. This is a patient with unstable angina, and this is a high risk scan. This is the rest status, and this is during stress. There is a clear defect in the inferior wall during stress, which reversed completely at rest, indicating severe stress-induced ischemia in the right coronary artery territory. The patient had PCI and optimal medical therapy and complete relief of symptoms. In diabetic patients, around 25% of patients, they may have ischemic heart disease, silent ischemic heart disease. So it's very important in patients with, and usually they present with shortness of breath only. So patients with diabetes mellitus type 2, they may present only with shortness of breath, and you do the myocardial perfusion scan, and you find that the patient has significant ischemic heart disease. So in patients with the DIAD study, this is a large study done in 22,000 patients in the States. They found that 22% of patients with more than 2 risk factors with diabetic patients, they have ischemic heart disease, and 22% of patients with less than 2% risk factors, 45 of 204, they had ischemic heart disease. In women, the MPI also plays very important role. In patients with low probability, you don't consider any myocardial perfusion scan. In patients with high probability, you do MPI or stress echo and consider angiography. But female patients with intermediate probability of coronary artery disease, you should do myocardial perfusion scan to screen for ischemic heart disease. Just a few words about the myocardial viability. Myocardial viability can be assessed by thallium, using thallium. This is early images. This is delayed images showing viable myocardium, or using FDG. This is myocardial perfusion using ammonia. And when we used the FDG, there was glucose consumption in this perfusion defect, indicating viable myocardium. But also, you can assess myocardial viability using MRI, which is now very commonly used, which shows delayed enhancement of the scarred myocardium, indicating non-viable. So delayed enhancement on MRI indicates non-viable myocardium. The absence of FDG uptake on a defect on ammonia perfusion scan or on thallium scan indicates non-viable myocardium. I'm sorry that we could not go thoroughly through this very important topic, but the time, and always we are the nuclear medicine people, we are the young brother of the radiology, so always they are bad treating us, but thank you.
Thank you, Dr. Osman, for this comprehensive lectures. Actually, the time was limited, and we apologize for the short time which we gave you, but you were able to finish in a reasonable time for our session. We'll open the session for discussion now. Okay, if there is no questions, we can conclude the session, and thank you very much for coming and giving us this two talks. Thank you very much. Thank you for everybody.
بسم الله الرحمن الرحيم. في ختام المؤتمر نود أن نشكر جميع الحضور من مشاركين من داخل المملكة وخارجها، ونود أن نشكر في الختام الشريك المنظم معنا في هذا المؤتمر، الجمعية السعودية الخيرية لمكافحة السرطان ومركز طيبة للكشف المبكر، والسادة شركة عطية الطبية وشركة ميديسيرف.
الدكتور محمد إيهاب رضا، الدكتور عبد الرؤوف ميمني، الدكتور خليل كردي، اللي بعد الدكتور صالح عثمان، شركة ميديسيرف الأستاذ معاذ العلي، شركة عطية الأستاذ أحمد البكري، الأستاذ أحمد عبيد حماد مدير الجمعية السعودية للمكافحة الخيرية لمكافحة السرطان بالمدينة المنورة. شكرا للجميع. طيب دكتور صالح السمير اسفين. خلاص
السلام عليكم.